The topic of discussion for today is the Cushing syndrome. But in order to understand the Cushing syndrome, we need to have a little basic knowledge regarding the adrenal gland. What is the adrenal gland? Adrenal gland is otherwise called as the suprarenal gland, and it is located over the superior pole of the kidney. Let's look at the histology of the adrenal gland. So the adrenal gland histologically is broadly divided into two groups. One is cortex, the other one is medulla. Let's look at the parts from the outer side. This is the zona glomerulosa. And the next inner part is zona fasciculata. And the inner part is zona reticularis. And the innermost part is the medulla. And these three outer parts together constitute the adrenal cortex. What does this zona glomerulosa produces? The mineralocorticoids. The hormone is aldosterone. Zona fasciculata produces the glucocorticoids. The hormone is cortisol. And zona reticularis produces 6 corticoids. The hormones are dihydroepiandrostenedione and androstenedione. And the adrenal medulla produces what? Catecholamines. Okay. Keeping that in mind, let's move on to the hypothalamo-pituitary axis. So this is the hypothalamus, and this is the anterior pituitary, and this is the adrenal gland. Okay. The hypothalamus produces the corticotropin releasing hormone. Under the influence of CRH, the anterior pituitary produces the adrenocorticotropic hormone, and under its influence, the adrenal gland produces the cortisol. This constitutes the trophic pathway or a stimulatory pathway. Now, this cortisol will have a negative feedback mechanism or an inhibitory activity on the anterior pituitary so as to suppress the adrenocorticotropic hormone. This is a trophic pathway, and this is a feedback pathway. Now let's talk about Cushing syndrome proper. What is Cushing syndrome? Cushing syndrome is nothing but the constellation of clinical features that result from chronic exposure to glucocorticoids. And we have to make a clear distinction from the Cushing's disease. Cushing's disease is nothing but the Cushing syndrome itself, but it is arising from a pituitary corticotrope adenoma. Okay, so the Cushing syndrome is a group of symptoms arising because of excessive glucocorticoids, whereas Cushing's disease is Cushing syndrome only, but the cause is corticotrope adenoma from the pituitary gland. Let's look at the causes of the Cushing syndrome. The causes of Cushing syndrome is broadly classified into two groups, the ACTH dependent Cushing's and the ACTH independent Cushing's. Why do we need to classify this Cushing syndrome under the ACTH dependent and the ACTH independent? Let's look at that now. So this is a pathway that you already know of, but let's suppose there is a tumor at the level of the pituitary gland. This tumor is producing significant amounts of ACTH, and under the influence of ACTH, the adrenal gland produces cortisol. Okay, and this cortisol will not be able to mount a significant negative impact on the anterior pituitary because the pituitary gland is having a tumor. And hence, this increase in cortisol is because of high ACTH. We call it the ACTH dependent Cushing's. Let's look at other scenario. Let's suppose there is a mass or a tumor at the level of the adrenal gland. When this adrenal gland is having a mass, it will produce high amounts of cortisol. And this cortisol will have a negative inhibitory action on the pituitary gland, because of which the ACTH level is reduced. Okay. Since this high level of cortisol is not under the influence of ACTH, we call it the ACTH independent Cushing's. Cushing's what? ACTH independent Cushing's syndrome. Okay. There are some more causes as well. Let's look at the ACTH dependent Cushing's. The first one that we have already mentioned, that is Cushing's disease, and it accounts for 75% of cases. The ACTH can also be produced from other sources as well. They are mostly tumors. They are the bronchial or the pancreatic carcinoids, medullary thyroid cancer, and the small cell lung cancer. The other one is the pheochromocytoma. These are also the tumors which can produce ACTH. We just have to keep them also in the mind. Then let's look at the ACTH independent Cushing's. ACTH independent Cushing's in the sense the production of cortisol is not under the control of ACTH. It means that the mass is at the level of the adrenal gland only. So they can be adrenocortical adenoma, adrenocortical carcinoma, and the hyperplasia of the adrenal gland. A miscellaneous cause is McCune-Albright syndrome. The McCune-Albright syndrome has a triad of capillate spots, precocious puberty, and polyostotic fibrous dysplasia. Okay. Next, move on to the clinical features. So the clinical features we'll discuss system-wise. Firstly, how does this high levels of cortisol have an impact on the metabolism? Let's look at the effects on the carbohydrate, fat, and the protein metabolism. On the carbohydrate metabolism, this will have high levels of gluconeogenesis. When the gluconeogenesis is high, what is gluconeogenesis? Firstly, gluconeogenesis is nothing but production of glucose from the non-carbohydrate sources. So when there is high amounts of glucose, this may lead to the glucose intolerance, and since this is occurring because of the adrenal gland, we call it the adrenal diabetes. How does it affect the fat? There is significant amount of redistribution and lipolysis as well, because of which the patient will have centripetal obesity and dyslipidemia. How does this affect the protein metabolism? There is significant catabolism or breakdown of the protein, because of which the patient will develop the proximal myopathy. Okay. Let's move on to the bone metabolism. On the bone, the effect, if you have to understand the effects on the bone, you have to understand the functions of cortisol. The cortisol have decreased calcium absorption from gut or from the kidney, and there is also increased calcium resorption from the bone. So either way, it is not letting the proper mineralization of bone. That's why the patient will have osteopenia and the osteoporosis. Okay. Now let's look at the effect on the cardiovascular system. These glucocorticoids also have some amount of mineralocorticoid activity, and this mineralocorticoid activity will result in sodium and water retention. And this sodium and water retention will result in edema and hypertension. The patient already had dyslipidemia as well, because of which the patient is more prone to get atherosclerosis and the related cardiovascular or the cerebrovascular events. Let's look at the effect on central nervous system. The patient will have irritability, emotional lability, anxiety, depression, and the patient can also have frank psychosis as well. Let's look at the effect on the blood and immune system. So the patient will have, we have already seen the high incidence of mucormycosis cases in the patients of COVID who received the glucocorticoids. So it is quite apparent that when we use the exogenous steroids, there is high incidence of infections. Not only just the fungal, there is increased incidence of bacterial infections as well. But a controversial point here is that the cortisol will also result in high WBC count. So you should understand certain points here. Just because the white blood cell count has increased, it doesn't mean that our immune system is more powerful now. What happened here is that the under the influence of high amounts of cortisol, there is a decreased cytokine release. Let's suppose there is some infection or inflammation at some site. The nearby leukocytes get accumulated there and they will result in cytokine release. And that results in chemotaxis or the transfer of the TLC to that site of inflammation or infection. But what happens when there is significant low cytokine release? There is decreased chemotaxis. And since the leukocytes are not getting shifted to the site of infection, relatively the leukocytes are more in the blood itself. That's why the patient will show increased leukocyte count when we look at the blood picture. And there is eosinopenia as well. And one of the effects on the coagulative system is that the patient will have hypercoagulation and the patient will further develop deep venous thrombosis and the pulmonary embolism. The mechanism behind this is not clear, but it is found that the von Willebrand factor levels are high in cases of the Cushing syndrome. Let's look at the effect on the reproductive system. The patient will have decreased libido, the patient will have amenorrhea and acne and hirsutism. Why is this? You should remember that all these three manifestations are common in women. This glucocorticoids will also have the action of sex corticoids to a very small extent. This sex corticoid activity will result in androgenic effects in the women. And another cause is that these glucocorticoids will have an inhibitory action on the hypothalamus, and this will result in decreased production of gonadotropin releasing hormone, and decreased levels of gonadotropin releasing hormone will result in low amounts of LH and FSH and further low amounts of estrogen. This low amounts of estrogen will result in the androgenic effects in the woman. Okay. Next comes the manifestations on the skin. How does it affect the skin? The patient will have facial plethora. The patient will have thin and brittle skin, easy bruising, and then the broad and purplish stretch marks. Why is this happening? There is significant fat redistribution, because of which the subcutaneous fat which is there, it is getting reabsorbed and it is getting redistributed to some other parts of the body. And another point is that there is significant protein breakdown as well. That point that we caught at the level of the metabolism. The collagen is also such a protein which is broken down in Cushing syndrome. Okay, when the collagen is broken down, the skin becomes thin, and these presentations are quite common. Now that we've seen all the clinical features, let's look at the diagnosis. So what are the two important steps? The first step is to confirm the diagnosis of Cushing syndrome, and the second step is to find out the cause for it. Okay. So this is the actual chart that has been given in the Harrison's. We'll break down into the simple steps. Firstly, as soon as you have a clinical suspicion based on the features that we have discussed, the first step is to exclude the exogenous Cushing's. The patient may be having some autoimmune disease in the past, because of which the patient may be on the exogenous steroids, or the patient may be having uncontrolled type 2 diabetes mellitus or pregnancy or some kind of infections in the body, because of which the hypercortisolism can be a compensatory response. It is otherwise called as the physiological hypercortisolism. That also we should rule out. After we rule out these two, then we can go ahead with the evaluation for the proper Cushing's syndrome. How do we evaluate? How do we do that? In order to understand the evaluation of the Cushing syndrome, first you have to understand the diurnal variation of the diurnal variation of the cortisol in the body. So this is unlike the thyroid disorder, where you will directly estimate free T4, T3, and TSH. The levels of cortisol vary throughout the day. That's why you have to measure cortisol at specific time stamps. You can see in this graph It starts peaking by early in the morning and reaches a peak by 8 a.m. to 9 a.m. And it will again fall down and reaches the baseline at approximately 12 a.m. So this peaking at 8 to 9 a.m. and the baseline at 12 a.m. are the two specific points where we'll usually measure. Okay, how do we measure? Let's look at it now. So we'll measure 24-hour urinary free cortisol. Okay. So when we are checking for 24 hours, these variations are dampened out. And if the level is more than 2 times, then we can consider the diagnosis of Cushing syndrome. We can also do midnight salivary cortisol. The other test that we can do here is the dexamethasone overnight test. What is dexamethasone overnight test? So we have 2 days. On day 1 at 11 p.m., we are going to give the patient 1 milligram of dexamethasone. Okay. And on day 2 at 8 a.m., we are checking the serum cortisol level. Okay, what is the principle of this test? When you give dexamethasone to the patient, okay, this will have an inhibitory effect on the hypothalamus or anterior pituitary, and this will result in low ACTH. This low ACTH level will further result in low cortisol. Okay, if the patient was normal, the cortisol level is to be suppressed. But if the patient is having Cushing syndrome, the cortisol level will be still high despite we give dexamethasone. Okay, this is the principle behind the test. And if you are still in doubt, then you can confirm the diagnosis by giving some more dose of dexamethasone, that we call it as the low dose dexamethasone suppression test. For this, we have to consider 3 days. And on day 1 and day 2, we'll give 0.5 milligrams of dexamethasone 6th hourly, 4 times a day for 2 days, and then we'll estimate the 8 a.m. cortisol. Despite giving 0.5 milligrams in this schedule, if cortisol is still high, then we can confirm the diagnosis of Cushing syndrome. And among all these investigations, if someone asks you what is the most sensitive test, the midnight salivary cortisol is the most sensitive test, and the low dose dexamethasone test is the most specific test for the diagnosis of Cushing's syndrome. Now that we confirm the Cushing syndrome, the next step is to find out the differential diagnosis. We know that the Cushing syndrome is broadly classified into 2 groups based on the ACTH levels. That's why let's do the plasma ACTH levels. If the plasma ACTH level is high, we call it as the ACTH dependent Cushing's. But if the plasma ACTH level is low, we call it as the ACTH independent Cushing's. Okay, let's look at the further evaluation of the ACTH dependent Cushing's. So we know that 75% of cases of Cushing syndrome can be because of the pituitary corticotropadenoma. That's why we have to do MRI brain. And along with that, we'll also do the high dose dexamethasone suppression test. Okay, if the MRI pituitary or the MRI brain may show a tumor at the level of pituitary gland, or we have to understand the high dose dexamethasone test here as well. Let's suppose in the high dose dexamethasone test, we are going to give 2 milligrams of dexamethasone 6th hourly, that is 4 times a day for 2 days, and we are estimating 8 a.m. cortisol. Okay, if we are giving this high dose of dexamethasone, there is a chance that this cortisol may be suppressed. Okay, is this suppressed or is it still high? If it is suppressed, it means that the hypothalamus pituitary axis is still intact. Okay, that could be the resultant effect from a pituitary adenoma. Okay, if the cortisol level is still high, it means that the result is from a ectopic ACTH syndrome. Hope you understood this. So if the high dose dexamethasone test is positive, then the diagnosis is Cushing's disease or the pituitary corticotropadenoma. Or if the high dose dexamethasone test is negative, or if the MRI brain does not reveal any adenoma, then the diagnosis could be an ectopic ACTH syndrome. You have to further do a PET scan because the carcinoids, small cell lung cancer and the medullary thyroid cancer, these are carcinomas which may require the PET CT for finding out the diagnosis. So let's look at the evaluation of the ACTH independent Cushing's. How do you evaluate it? We know that the pathology is at the level of the adrenal gland, so we can right away do the CT abdomen. If the CT abdomen may reveal a unilateral mass or a bilateral mass. If there is a bilateral mass, it could be the bilateral micronodular or macronodular adrenal hyperplasia. But if it is unilateral, it could be an adrenal adenoma. Okay, sometimes there could be a tumor as well, because we have to do the further evaluation to rule out the adrenal carcinoma again. Okay. Now that we have reached the different causes of the Cushing syndrome, let's look at the treatment. How do we treat? The first one that we have to treat is the Cushing's disease. So the Cushing's disease management, the Cushing's disease is because of a pituitary adenoma. So the treatment of choice could be just removing the tumor, right? So the surgical management is the treatment of choice, and the surgery that we are doing here is the transsphenoidal hypophysiectomy, or the transsphenoidal surgery, where we are entering the base of the brain through the transsphenoidal route and we are removing the pituitary gland. Okay, it is the treatment of choice. And if we are not able to do the surgery because of severe Cushing syndrome, we may have to treat the patient firstly with the medical management. Okay, so how do we treat? There are various drugs. Most of them are having the action at the level of the steroidogenesis. What are those drugs? First one is the metyrapone. It has the effect on the inhibitory effect on the 11 beta hydroxylase. And the other drug is ketoconazole. It also inhibits steroidogenesis at the multiple levels. Next one is osilodrostat. It is the recent drug which has been added in the 21st edition of Harrison's. Next one is the etomidate. It is actually an anesthetic drug, and it should be given as the IV route. It also inhibits 11 beta hydroxylase. The next drug is the pasireotide. It is a somatostatin receptor agonist. It can also be used in the Cushing syndrome. And the last one is the mitotane. It is an anti-cancer drug which has the activity of anti-steroidogenesis. That's why it is primarily used in Cushing syndrome resulting from adrenal carcinoma. Okay. So what is this? Where is this 11 beta hydroxylase? If you look at the pathway of steroidogenesis, the roundup enzyme is the 11 beta hydroxylase. It is the last enzyme that is required for the production of cortisol. So there are some more other causes as well that we have found out at the investigation. If the patient is having bilateral adrenal hyperplasia, you can remove both the adrenals by the bilateral adrenalectomy. If the patient is having unilateral adrenal mass, you should first evaluate and remove the tumor. If it is only adrenal adenoma, we can do the unilateral adrenalectomy. If the patient is having ectopic ACTH syndrome, for that you have to do a PET-CT scan and localize the tumor and remove it. Okay. Now, if the patient of Cushing's disease, we have done some surgery. After the surgery as well, if the patient recurs with the similar complaints of Cushing's syndrome, then the modalities that we have are the second surgery. If there is any residual matter which is left in the pituitary, we'll remove that by doing the second surgery, or you can do the radiosurgery, or you can do the stereotactic radiotherapy. And the last one, the last resort is the bilateral adrenalectomy. Okay.